guys, we are back with Dr. Graham Bayes today to talk about total knee replacements and partial knee replacements. Thank you for joining us again. Appreciate it.
Thanks for the invite, Tim.
Cool. So tell us about the different grades of degeneration and when do you actually decide to do a knee replacement?
Okay. So the wear and tear process is a natural phenomenon in all of us. You know, we're born with articular cartilage. As we use it, a large extent to how much wear and tear there is determined by genetics. It's also determined by the amount of activity that you use your knee with, as well as previous sort of injuries. So fractures or injuries to the joint or previous meniscectomies, those sort of things all contribute to wear and tear in the knee.
Okay.
So different parts of your knee get affected. In general, the vast majority of the population, your mechanical axis, which runs from the center of your hip down to the ankle, usually slightly favors the inside part of your knee or the medial side.
So that will weigh more, the inside part?
Yeah, so in general, that's what happens. Obviously, there's exceptions, but that's the sort of general rule of thumb.
We often speak about we don't treat an x-ray, we treat the person. So do you, if you see an x-ray with a really bad knee, do you immediately go and operate, or when do you decide to do that?
Yeah, so that's actually the most important thing. So anything in medicine, I've probably said that before, is always, you've got to treat patients, you don't treat x-rays or other investigations.
Okay.
So you might have a population of 100, 50 of them have wear and tear in the knee, have no complaints whatsoever, you don't touch them, regardless of what those x-rays look like.
Okay.
So the most important thing is you have to take a good history and find out what the complaint is.
Okay.
So the vast majority of patients who are coming for a consult who may or may not be a candidate for a knee replacement often complain of pain.
So quickly show us the different phases of osteoarthritis. We have some models here.
Okay, so just broadly speaking, a normal knee is kind of represented in this model that we have.
Yeah.
The articular surface is represented by blue markers here. The meniscus is represented by this sort of opaque sort of picture here. So with pristine cartilage, it's actually white in nature. It's got no defects in it. There's no formation of any osteophytes. There's no narrowing of the joint space, and the knee alignment is generally normal.
Yeah. Okay.
As we get more wear and tear, so like I said, the general population sort of wear and tear more on the medial side, it starts to degenerate more on the inside than the outside. It can be the compartment, but that's represented here.
Okay.
That's probably a bit of a false sort of view on this, because it takes a while for that wear and tear to happen. It doesn't sort of suddenly go from normal to suddenly no articular cartilage.
Okay.
As we get degeneration, we get more and more wear. It seems to be a process that affects one compartment and then will affect the second compartment. And what's not represented here is that you obviously have the patellofemoral joint as well that can be affected too.
Okay.
So the end stage osteoarthritis is pretty much represented by this poor little guy. It's got all the formations of osteophytes. You can see there's joint space narrowing, there's advanced articular wear, and more than likely this knee is also going to probably have a slight deformity.
Tell us what you actually do when you do the knee replacement.
So a knee replacement is pretty much a resurfacing of the joint.
Okay.
So the idea there is to resurface the femur,
Yeah.
resurface the tibia, and then you replace it with metal and plastic.
So you literally saw off the
end.
bad part, the end parts
Yeah.
of the bone, and then you replace that.
Yeah. So
Okay.
you pretty much resurface it in such a way that it matches the prosthesis that you're going to use.
All right.
And the principles really there is to restore the joint line and restore stability.
Okay. What knee replacements do you do?
So I do both partial knee replacements.
Okay.
I also do total knee replacements.
Okay.
And there's various ways of doing both.
Yeah.
So my partial knee replacements is for those who have early osteoarthritis, which only affects one compartment.
Yes.
The idea there is it works on the philosophy of ligament balance.
Okay.
So you're trying to restore the joint line and the ligament balance to exactly what it was before.
Okay.
And in so saying, it's sort of recreating the constitutional joint alignment and anatomy. When it comes to the total knee replacements, then I use what I like to call constitutional realignment as well.
Yeah.
It's a modified version of measured resection. The joint is restored to exactly where it was anatomically before, both on the femoral side as well as on the tibial side. And those are the two techniques I use broadly.
So you're trying to match what the patient had already,
Yes,
and you're
yeah.
just basically fixing the the sore parts.
That's it. There's many advantages to the partial knee replacement, so that's why I like to do them early.
Yes.
The patients are candidates,
Yeah.
simply because you've got high patient satisfaction rate,
Yeah.
quicker recovery, it's a lot quicker, simpler, less blood loss, no complications, so
Okay.
the whole package seems to be a lot better. So it all comes down to the history once again. So if you've got a patient who's got debilitating pain, poor quality of life, tried other modalities of treatment and they're simply unhappy.
Mm.
If you look at the x-rays, and you have to do a special set of them, but what you have to make sure is that you do have 2 compartments out of the 3 that is preserved.
Okay.
So if, for example, you've got medial compartment wear, that's the most common.
Yeah.
If the lateral side is normal and the patellofemoral joint is normal, that's when a patient is a good candidate for a partial knee replacement.
Okay. Can they go back to sport if they had a partial or high impact sport, or is it the same as a total? You can't really do high impact after that.
So when it comes to arthroplasty, the general principles are exactly the same.
Okay.
So what I try to remind all my patients about, and they ask me the same question,
Yeah.
is that you have to remember that you're replacing something that's biological with something that's mechanical.
Yes.
Anything that's biological has a blood supply, it's got healing potential, so it can remodel
Yeah.
and it can sort of regenerate.
Yeah.
The problem is when you're putting something mechanical, like metal and plastic, which a knee replacement basically is,
Yeah.
there's no heating potential. So I always make the analogy, if you have a Ferrari and you've got a brand new set of tyres on it,
Yeah.
if you drive it around in the suburbs, it will last you a long time.
Yes.
If you take it to the racetrack every weekend, unfortunately it's going to
Okay.
wear out pretty quick.
What is the recovery time for knee replacements, and is the partial quicker than the total?
So it's difficult to set an endpoint to what is the recovery time. But in general, what I tell my patients is when it comes to your total knee replacement, it's around about the 3-month mark where you have your life back.
Mm-hmm.
In other words, going around shopping centres, hardly taking any analgesia, can do some longer walks, return to certain things like the golf course, usually 3-4 months. Cycling is sort of pretty easy.
Yeah.
However, they will still have some residual, warmth and numbness, all the
Okay.
little things that happens
Yeah.
with a knee replacement.
Okay.
When it comes to the partial knee replacements, the recovery seems to be about half the time.
Okay. So you and me spoke a lot about the rehab post-op, and it seems to be a theme that people with joint replacements just want to get back to walking fine without pain, and they're good to go. And they don't really go and strengthen their muscles afterwards, and then years later they struggle. Do you think it helps to do the rehab?
If we have to look at traditional knee replacements and why we did them, it's your old granny or grandpa that's got a bad knee and they sort of live with it for a while.
Yeah.
You do a knee replacement, you simply want to give them a pain-free knee.
Yes.
The modern day knee replacement, we are seeing younger and younger patients with end-stage osteoarthritis, high demand, and they have high expectations to return to normal activity.
Yeah.
So we do know that there are a number of studies that with osteoarthritis or degeneration and development of a painful knee, you do get weakness of quads, hamstrings, core muscles, all the things that you guys work on.
Yeah.
Now traditionally, we never really explored this avenue, but certainly that there's great value in this, and we've seen it in practice.
Yeah.
Is that if you don't do the rehabilitation afterwards, you're not going to get the benefits of a pain-free knee as well. So you will have limitations.
Okay.
So in my opinion, that the rehabilitation is probably more important than doing a good knee replacement. That's sort of just the one part of the story. I still have to do my job right, but patients have to understand that there are going to be limitations. However, we can get them back to a level where they'll be much happier.
Yeah.
We know that traditionally with most knee replacements, and if you read the literature, 20% of patients are going to be unhappy with their knees.
Okay.
And largely because they cannot get back to their activities, but there's never been a more a prudent time or a time now where we have to focus on, okay, after the operation, what now?
Yes.
And I think that traditionally rehab involved physiotherapy, that would involve getting the knee straight, that would get it bending, that would get you sort
which
of
is
pain-free.
very important.
It's very important,
Yeah.
but now we have to look beyond
A
that.
bit further, yeah.
Yeah.
Alright, so do you find that your patients are generally happier then if they do some strengthening and rehab afterwards?
There's absolutely no doubt.
Okay.
There's a great drive, and I think that the way going forward is that, and what we see definitely is those who do even pre-rehabilitation
Yeah.
So quad strengthening and all that sort of stuff, prehab.
Yeah.
They undergo the surgery and then they come out afterwards.
They recover quicker and better.
Those group of patients are far happier,
Yeah.
and they recover a lot quicker and get back to normal activities quicker than those who don't do it.
Awesome, great. Why do people land up with revisions?
So revision surgery is reserved for patients where there's a failure of the previous implant or the initial implant. There's 2 or 3 large groups. So one would be instability. So we spoke about gap balancing.
Okay.
So if you've got a patient that's got a knee that's just not functioning well and it's dislocating or they can't do stairs, we're unhappy with it. There's a lot of instability. That could be a reason to do it. Number 2 would be aseptic loosening, which means that there is no infection around, but we do know that with polywear we start getting osteolysis and we get loosening of the prosthesis.
Okay.
But the loosening of the prosthesis often leads to either instability or pain if the patient's fond of it.
Okay.
The other reason, or the other big reason, is sepsis. So
Yeah.
if you have a joint that is septic, it's going to be
Gotta take
painful.
it out.
It's going to cause osteolysis. So then you need revisions. Those are the sort of biggest groups that you can find.
Alright. What is the lifetime of a knee?
Of a knee replacement.
Yeah.
Yeah, so if we divide it largely into partials, totals,
Yeah.
total knee replacements, that's still the gold standard of knee replacements.
Mm-hmm.
So if you're an arthroplasty surgeon, you don't do too many partial knee replacements. That's your go-to knee. If you look in the literature these days, 20 to 30 years, you're looking at about a 90 to 93% survivorship.
Okay.
If you're a regular uni user
Yeah.
and you do more than 20% of your practice and you're doing more than 12 a year and you're doing it quite regularly, you're looking at 90% survivorship, probably just a little bit lower than the total knee replacement if you do it correctly. However, if you do not do unis regularly, the results are dismal. That's what gives it's a bad name.
Yeah.
So if you choose a surgeon and they want to do a uni on you, just make sure that they're high volume, otherwise you're not going to get as good a